Hello, everyone. Welcome to our webinar, The Changing Landscape of E&M Codes in 2021 and What You Need to Know. We are expecting significant changes and revisions in the E&M codes in just the next 3 months. So in this webinar, our goal and focus is to inform you about the important changes to the E&M codes, top changes in the ICD10 codes, how will these changes affect your documentation, and how would you calculate or determine your E&M level in 2021? So with this, I am Diya Ranjan, and joining me in today's webinar is my co-organizer, Shani Yellen. Shani is the Senior Client Manager for RCM Services. So thank you, Shani, for being here. Let me also introduce you all to our presenters for today's session. We have Kristen Nehk. Kristen is the Vice President of Revenue Cycle Management Services at Bizmatics. And Kristen has years of expertise in RCM and has presented on various topics related to revenue cycle in many of our earlier webinars. Joining Kristen is Melissa Castillo. Melissa is our coding executive with Bizmatics, and Melissa has 20+ years of experience in coding. So welcome to both our presenters today. I would also like to elaborate on a few rules and resources for this webinar before we begin. We do have a question and answer session for this at the end. So please send your questions by typing it in the question box on the right side corner. We have a few polls, so please put in your answers once the polls are displayed. The recording of this webinar will be sent to all of you in a follow-up email, and Prognosis customers can also access it from our resource center. And last but not the least, we have a very short survey right after the webinar. So I would request all of you to please put in your questions, your answers to all those questions, as they will be very helpful for all of us. So let's begin, and I begin with the very first poll. And the question is, are you aware of the upcoming changes in the E&M codes in 2021? And I will keep it open for some time for you to answer. Okay, just a few more seconds and I will close it. So the answers, 44% say yes, and 56% say no. So with that, I am handing over the session to our first presenter. Melissa, it's over to you now.
Thank you, Dia. Good morning, everyone. We're going to go ahead and go over these changes that are coming for 2021. CPT code 99201 will be deleted. A provider can either determine the E&M by medical decision-making or time. Medical decision-making guidelines have changed. Level of history or exam are not a requirement in determining an E&M level. Non-face-to-face work is now included in time if done the same day as the visit. Changes to time. As you can see, we have columns. The 2020 guidelines, 99212 was 10 minutes, but now for January 1st, it will be 10 to 19 minutes. 99213, 15 minutes will now be 20 to 29 minutes, and so on. And then 99202 was 20 minutes. Now it will, in 2021, it will be 15 to 29 minutes. 99203, 30 minutes will now be 30 to 44 minutes. 99205, next slide. Activities included in time. Per AMA, you want to list the activities performed and time associated with each activity. Preparing for the patient may include reviewing tests, history of referring providers, non-face-to-face time. Examination, counseling, and education. Ordering procedures, medications, imaging. That's also non-face-to-face time. Discussions with other healthcare professionals. Interpreting results. If the physician is billing modifier 26 for a test, the professional component, he can include this in time spent. You cannot include time on items separately reported, such as care management EMG. You cannot include staff time. Time is based on only physician time, and the time has to be based on the same day as the visit. Prolonged services code changes that are coming. AMA will release a new prolonged service code. It has not been created yet, and it can be reported with 99202 through 99215. You can no longer use the 99358, 99359, 99354, 99355 with E&M codes into 2021. Complexity is going to guide the coding over bullets and systems. There is no required level of history or exam for a specific E&M level to be met.
I'm going to add something here really quick. Okay. I'm just going to jump in. So this section right here that we've highlighted is from the AMA directly. And if you notice the last sentence on the paragraph that the AMA published, it does state that the extent of history and physical examination is not an element in selection of office or other outpatient services, which is different from the way you currently code an E&M in 2020 or in the previous years. So in the past, where you would be driven by your bullets and physical exam to determine your E&M level, now everything's going to be based on either time or medical decision making.
Yes, it'll be based off time and medical decision making, but you still do need to document your histories. These are the elements for medical decision making. For 99211, it's still the same, not applicable. 99202 and 99212, straightforward, one self-limited or minor problem, minimal or none, and just goes up from there. Minimal risk or morbidity and additional diagnostic tests and treatment. And then 99203 and 99213, they're all the same now. So low is 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Limited, you must meet the, and then 99204 and 99214 are moderate, and 99205, 99215 are high. So the table shows that moderate, you must meet the requirements at least 1 out of 3 categories. And extensive for 99205 and 15, extensive, you must meet at least 2 out of 3 categories. (99203) medical decision making now in 2021. Currently, you have 1 worsening or established problem. For 2021, you have to have 2 or more self-limited or minor problems. Currently, you can also have acute uncomplicated illness or injury, or 2 stable problems. 2021, 1 stable chronic illness such as diabetes, or 1 acute uncomplicated illness or injury such as cystitis. Documentation examples for 1995 and 1997 guidelines. They were based on bullet points for the HPI, PFSH, review of systems, and physical exam, along with the medical decision making to support all the levels of service. For 2021, medical decision making will now be the primary determination of levels of service. The new 2021 guidelines focus on documentation that supports the MDM and diagnosis. Therefore, items such as labs and x-rays, along with their interpretations, will need to be documented within the body of the note.
Okay, here is another poll for you. And the question is, do you struggle with ICD10 coding? And I will leave this on for a few seconds till you all answer. Okay. 2 or 3 more seconds, and then I will close the poll. All right, the answer is 24% say yes, they struggle with ICD-10 coding, and 76% say no.
Thank you, Dia. Okay. So we're going to shift briefly to the ICD-10 coding section. There are a lot of changes that are actually being released tomorrow. So these all go into effect tomorrow. So the first thing we wanted to review was a section within Prognosis that will help you with your ICD-10 coding. So from here, if you're in the patient's assessment screen and you go to the plus sign to pick your diagnosis code, you have this drill down option. The drill down option allows you to put in, it's a shoulder injury, and it's going to ask you questions. So you would answer, this is the initial encounter, subsequent encounter, sequential. Is it a right, left, or unspecified laterality? You want to try to avoid unspecified. So if you were to say it's the initial encounter on the right side, it's going to populate the appropriate ICD-10 code. And then you would just click the plus sign. It's going to put it over here for you to add to the assessment, and you can keep typing other problems. You can say abdominal pain. Again, this arrow allows you to answer questions to get the correct ICD-10 code, and then it will populate it here for you. And then when you click OK, it's going to pull it to your encounter. And going back to our slides. So tomorrow, all of the code changes take effect for 2021. There are over 550 proposed code changes that are going to go into effect. That includes 490 new codes, 47 revisions, and 58 deleted codes. We're kind of giving you an overview of the top ones in this webinar. There are several chapters strictly dedicated to COVID-19 and new documentation rules related to COVID-19. So when the pandemic first happened, there was a lot of back and forth on documentation and, you know, if you had to put anything in when a patient tested positive or how you would get paid for your COVID-19 tests. Now they have published a book with those chapters that clearly give you guidelines on how you have to document in order to get paid after tomorrow. If you have a clinic that does a lot of testing or you see a lot of COVID patients, you'll definitely want to download the ebook. And it's about the first 3 to 4 chapters are on the COVID-19 updates. So for DX code U07.1, it's now going to require that the physician indicate whether the patient is positive or confirmed in the note. So he specifically has to say it was a positive test or confirmed test in order to get paid or to use that code. There's also new diagnosis codes for illnesses related to vaping. And now patients can self-report problems related to education or psychosocial circumstances. If a patient chooses to self-report a problem related with education, the provider will have to document that the patient is self-reporting this and sign off on it. So again, we do recommend that if you do see a lot of COVID-19 patients or you do the rapid testing or any of the COVID-19 testing, I highly recommend you download the ICD-10 book for 2021 and just review the new documentation rules around billing and getting paid for those. And again, this all takes effect tomorrow. And then just to review on our E&M section really quickly. So in 2021, 99201 is going to be deleted. 99211 will still be active, but there's no time associated to 99211. And then doctors can now pick the level of E&M based on time alone versus in 2020 in the past, it had to be based on the bullets. The physical exam led it. That's no longer the case. While he still has to document his physical exam and HPI, it's not the determining factor in his level of care. And then the things included in time, your non-face-to-face items. So if he is on the phone with another physician talking about the patient, or he's reviewing a note from another doctor, x-rays from another doctor, an MRI before seeing the patient or after, that all is included in time, but he will want to make a mention in his notes what he did and how long he did it for. So if he spent 20 minutes in review of imaging or MRIs, he's going to want to list that on his progress note to support the time. Questions, Tia?
I just have one, Kristen, as of now. When were those changes going to be made in Prognosis?
So in the E&M section of Prognosis, and I'm just going to show my screen really quick so everyone knows what I'm talking about. From the encounter, you have this E&M calculator here. This section, if you have a provider that uses this section to pick their E&M, our development team is currently redesigning this for 2021, and we'll keep you posted on the release date for those changes. So the way this works, just as a brief example, the provider could say they want a code for 99214, and down here it's going to tell him what he actually has. So if he needs a detailed history, it'll tell him if he has one. If he needs 4 elements in an HPI, it's telling the doctor he doesn't have any, so he'd need to add 4. Review of systems and physical points. If he then tried to save this, there will also be an alert that'll pop up that'll tell him what he has to modify.
All right. I will request everyone to send in the questions in the question box. I do have a few more which came in, Kristen. So do you want me to get started?
Yeah.
With the questions that have coming in? Okay, all right. So the next question that we have is, should we be picking unspecified ICD10 codes?
No, you want to avoid those at all costs. So there are some payers currently that are denying if you pick an unspecified ICD10 code. Tia?
Yeah, Kristen?
Oh, that was my answer. Sorry.
Okay, yeah. So the next question is, since 99201 is deleted, can you bill a nurse visit?
Yes, you can bill a nurse visit with 99211 because that is still active, as long as they're an established patient.
Okay, all right. So the next question is, are the new CPT codes that are effective 10/1/2020 already loaded or deleted in Prognosis?
So the ICD10 codes that are effective tomorrow will be loaded into Prognosis, yes. So tonight, all the changes will happen. So if it's a deleted code, you're going to notice tomorrow that it's no longer, you can't pick it anymore, and you'll see all the new codes.
Okay, moving on to the next question. So for 2021, does time need to be documented on the note?
Yes. So, well, yes, if the provider is going to use time to determine his level of E&M.
All right. Moving on to the next, what code is getting deleted?
Or CPT or ICD10. Is it for CPT? Or E&M levels? I'm sorry.
Yeah. So Melissa, it doesn't say anything. It just says what code is getting deleted. So maybe you can touch on them.
The 99201 E&M level will be deleted. I'm not sure Kristen, how many are they deleting for? Is it 58 they're deleting for ICD10?
Yeah, so they're deleting 58 ICD10 codes, and we can send you all those codes with this copy of the webinar. So you have the deleted ones.
Okay, all right. So the next question actually is, I can answer that. Can you send the slides to us via email? Yes. I wanted to reiterate that we would be having the webinar recording and the slides over to you in a follow-up email by tomorrow. So yes, you can have access to all the information that we are providing to you right now. So moving on to the next question, also for ICD-10, does the SNOMED code matter?
If you're going to be reporting meaningful use, yes, it does.
All right. Next question is, we are getting a lot of questions, Kristen and Melissa, so I'm just going on with them. So the very next question is, if we do an X-ray in office and read it, does that count in the time?
As long as you're not billing for it on the professional side, then yes.
So just to clarify, if you're doing the X-ray in your own office and you bill the X-ray, both the technical component and the professional component, it does not count towards time.
Okay. So the next question is, does this affect wellness or preventative visits also?
Yes, they will be affected also. And we can release with these slides those updates. The only codes that are going to allow you to use time and medical decision making are going to be the E&M codes, the 99202 to 99215. For all other codes, it's still going to be based mainly on bullets, HPI, physical exam.
Okay. So the next question is, will the upgrade occur automatically?
Yes. I'm assuming you're meaning for the E&M level, but the upgrade for that and the ICD-10s does happen automatically.
Okay. So moving on to the next question, if we bill for in-house labs, does the review count towards them, towards time?
As the labs are being billed out from the office.
Mm-hmm.
So
Or in-house labs.
if you're ordering your labs from LabCorp and the doctor's reviewing and counseling the patient on those labs, it does count towards time. If you have an in-office lab where you're actually running them there, depending on what kind of labs you run, we can send you documentation with the webinar that details which ones you can and cannot count towards time.
Okay. So moving on, the next question, does CMS have access to this to verify code used and payment?
Does CMS have access to?
Yeah, yes. Let me repeat the question again. Does CMS have access to this to verify code used and payment?
I'm not sure what the exact question is, but I know there are, if you were to purchase like AAPC, you can upload your progress notes to make sure that you're coding correctly. So you can do like an audit, basically, if you're wanting to make sure you're coding correctly.
Okay. Okay, so when we move on, I think you've kind of replied, but let me go on this question again. Are the ICD-10s with the drill down codes updated in Prognosis already to start using tomorrow?
Yes. So you should already be able to see it on your assessment today, the little drill down section.
Okay, all right. The next question again is on emailing the webinar details, and that will go out to everybody in the next one day. So as I said earlier, you will have access to all the information that we are providing you. So you will get the PDF as well as the recording of the webinar. So moving on to the next question, will there be a template to assist us in tallying uptime?
Yes, you can create a template that will help you, yes.
Okay. So for next question, for these new guidelines on the E&M codes, is there going to be a change in the reimbursements?
Yes, there will be changes in reimbursement, and there are going to be changes to the RVU values. They have not released what those changes are going to be yet, but we will have a second series to this webinar in the next coming months that will go through more of the changes as they become known.
Okay. So the next question actually is a request for sharing a slide. So can you show the slide with the times again? So Kristen, can we have that up, please?
Yeah. So let me just go back up here. I believe you mean this slide, which just goes over the changes. So, you know, in the past you had your like set, it's 10 minutes, it's 15 minutes, it's 25 minutes. They're changing them now for more like a code range, time range, sorry.
Okay. All right. So moving on, will RVU values change? The next question.
Yes, sorry. Yes, they will change. They have not said what they're going to change to. Once we have that information, though, we're going to be releasing a lot of articles and another webinar that will detail more information to you.
Okay. So the next question is, if code is incorrectly placed, how will a provider be notified? So this is one part. And then moving on to the next, is an actual biller coder able to alert a provider if an error is found? Do you want me to repeat the question again, Kristen?
Repeat the first part really quick, one more time.
Okay. If the code is incorrectly placed, how will a provider be notified?
I assume you mean incorrectly picked. And if you mean with the E&M calculator that we have, there's an alert that pops up right after he tries to pick it.
Okay.
If you use RCM, then our coders will alert the doctor if something is picked incorrectly. And then for the first few months, if time's not being documented. So since everything is shifting to medical decision-making or time-based, it is important that you put how much time was spent in order to justify that code.
Okay. All right. So moving on to the next question, what about charts that has not been completed now?
I assume you mean, so if you have open charts, let's say the ICD10 codes change tomorrow, you won't necessarily be able to pick one of the older codes unless you reactivate it. So there is a way to reactivate one of the deleted codes so that you can still put it on an older claim. For the E&M codes, so any date of service up to December 31st, 2020 would still follow the old rules. And then any date of service after January 1st and after is the new rules will apply. So if you have a lot of encounters open, you'll want to keep that in mind.
Okay. So the next question is on a code 99214. Is it only time-based or number of problem systems?
So 99214, sorry, go ahead, Melissa.
Oh, so now, yes, not for 2021. 2021 will be based off of medical decision-making or time.
Right, so not bullets anymore.
No more bullets.
So we have the slides here that will be sent to you on the medical decision-making, these. So this, if the doctor's going to base his E&M level on medical decision-making, he's going to want to follow these. If they're going to be basing it on time, again, he's going to want to make sure he's listing, you know, I spent 20 minutes on examination, I spent 20 minutes on counseling, 30 minutes on review of records, whatever he's doing.
Yes, time will need to be broke down to how much time was spent on each item. I don't think you'll be able to just write down, I spent 45 minutes with this patient's information.
So if you do use templates in Prognosis, you can have the template where it says, you know, review of imaging, counseling exam where the doctor can pick or put or insert how much time was spent, and then that'll go on his progress note.
Which is really helpful.
Okay. So moving on to the next question, how often do we have to bill claims-based codes in a year for a patient? Would you want me to repeat the question?
Yeah, sorry.
Yeah.
One more time.
So how often do we have to bill claims-based codes in a year for a patient? So this is talking about claims-based codes.
I'm not sure I understand the question. But if you can, or I will email you after this webinar just to get more information on what exactly the question is, and then we can answer for you.
Okay. I have noted the question, Kristen, so I will have it over to you.
Okay.
All right. Okay. So the next question is, will there be any specific documentation required when billing of MDM?
Yes.
Well, yeah, you would just need to document, let's say you're doing a 99203. If you're going to go off the minimal or none, or limited, let's just say you do 99203 limited MDM, you would have to have any combination of two of the following tests or documents. So review of external notes from each unique source, review the results of each unique test, order of each unique test. So you would need at least two of those, or an assessment requiring independent historians. But yeah, you still do need to document what your findings are to get to the MDM level that you want.
Okay. All right. So the next question is again has two parts. So let me read the first part. What if a provider has to view more than one image or labs? How will time be billed? What if one provider takes longer than another provider?
So that's what he's going to want to document. He spent X amount of time reviewing medical records or reviewing labs, and that will justify the code that he picks. I don't think it necessarily matters if a provider's faster than another provider at reviewing records, as long as he documents that he did spend the time.
Okay. So please do send the information for those of us with our own in-house labs. This is the next question. So
I will send you an article on that with the slides, just so you have an understanding of how that's going to work if you do in-house labs.
Okay. All right. And so the next question is, since the summary of this webinar will be available tomorrow, could you please summarize the changes that are effective 10/01/2020 and also show the screen of them to take notes?
Yes, so the ICD10 codes are going into effect tomorrow. So not the E&M codes, this is specific to the ICD10 codes that are changing tomorrow. And again, a lot of it revolves around COVID-19 and requiring more documentation, or to be more specific, when you are diagnosing a patient with COVID-19. So if you do have a clinic that does a lot of testing, you're going to want to make sure that I would definitely purchase the ebook and just read the first 3 chapters. And that will give you an idea of, again, they want you to be more specific. So if you are coding with the UO 7.1, they want you to put in your note, the patient is positive. And then the new diagnosis code for illnesses related to vaping, since that is an upwards trend right now. And then patients self-reporting education issues or psychosocial circumstances, meaning a patient can come into your office and say, I have problems that affect my education. The doctor would notate that the patient self-reported and then sign off on it. And then we will send you with these slides the 58 deleted codes that are no longer going to be effective after tomorrow.
Okay.
But again, if you have encounters open and you need to use one of the deleted codes from a previous date, you can reactivate them.
Okay, so moving ahead, Kristen. So this is from a pain management clinic. So the question is, we are a pain management clinic which monitors the patient's medication. But if a procedure is also done when the patient comes in for their 2-month medication refill, can we bill separately for the procedure and the E&M visit separately? Can we do that?
Yes, you're going to want to make sure you document both separately. They'll both go on the same claim, and there are some procedures that do bundle with the office visit codes, so you're going to want to be aware of that.
Okay. The next question, are injections included in the time, and can they still be billed with the office visit?
So they're not included in time because you're billing for them. So if you're billing for an injection, then it's not part of your time.
Yeah. Moving on, the next question, if patient has DM or PVD or other chronic illness, but we do not directly treat them for those conditions, do they still count for the number of problems addressed since they influence our MDM?
Yes, as long as you address them.
Okay. So a few more questions.
You just can't write them down. You have to address that they're on meds or that you counseled them on that illness.
Okay. So the next question is, where is the best place to document the time spent with patients?
I would honestly do it at the end of the progress note.
Yeah, I would do it somewhere on the assessment.
Okay, moving on. The code is, since the 99358 can't be billed with E&M visits, can we include this in the time?
So, no, well, okay, so there's going to be a new code that will replace 99358 for the E&M codes. So they're just saying that they don't want you to use 99358 with the 99202s to 99215s, but they're going to give you another code you can use for prolonged services. So if the provider needs to bill that code, it's still going to be available to him. They just haven't released what the code is going to be exactly. Once we know, though, we will send out an update for everyone, letting you know what that code is.
Okay. The next question is, so does the system eliminate a live biller?
No. I mean, no. I don't think you can ever really eliminate a live biller.
I would say no.
Yeah, if I understand the question correctly, no. I don't think it eliminates your biller or your need for a biller.
Okay. And I just to give you a break, I just wanted to mention again that the slides and the recording will be available to everybody after the webinar. And Kristen, can you have that slide up also for everybody, where we talked about, asking everybody to join us on our social media platforms, because we are very active on Facebook, LinkedIn, Twitter, and Instagram. So anytime, we have the updates there also. So we would be really grateful to have you all join us and look for latest updates, industry news, any product information, product updates, we post it all out. So please, these are the links, and please feel free to join us. And we also have, you can put in your questions or comments, so feel free to use it and connect with us. So moving on again, do we have to put time if I am using MDM to code?
No. So it's
Okay.
MDM or time.
All right. So the next question, are all EMR systems used capable of using this software?
The software. I don't know that I understand the question. I mean, we are an EMR
Yes.
software.
Yeah.
So we don't connect with like other EMRs because we are our own EMR.
Right. Okay, let's move on. So this is a question, and tell me, Kristen, if you would want me, Kristen or Melissa, if you want me to repeat. So I'm just starting off. So does the alert that pops up just basically say time was not documented? And then it says it would be nice to see kind of step-by-step documenting and coding in the chart for the time or medical decision making and picking the correct CPT code.
So in our second series to this webinar, we're going to have another one coming up in the next coming months. We will go over the documenting within Prognosis and those changes by our development team on the E&M selector. So that one will be more product specific and give you the opportunity to see the changes that are being made.
Okay, thanks. So moving on, the next question, the time has to be specified. The time has to be specified in the progress note. That is the question. So if so, we have to use the same way that we report the time of chronic care management services, like for family practice template.
I think I understand the question, so yes. But just to be sure I understood your question, I'm going to email you just to make sure I understand what you're asking, but I believe the answer is yes.
Okay, all right. I will note this for you, Kristen. So
just because there's two ways that could go, but I think I understand it, so I'm saying yes, but I'm going to follow up with you.
Okay, all right. The next question is actually, could we get Melissa and Kristen's email for future billing help? So I am noting down this, the email also. So Kristen, maybe you can reach out and provide your details.
Yes, I can include it on the webinar slides that Dia will send out to you.
So everybody has that, right? Okay. So moving on, is there a way to calculate nursing E&M for provider-based clinics?
Nursing E&Ms, do you mean like nurse practitioners, or I guess I would need more information on what you mean by nurses. I will email you as well just to get an idea if you mean nurse practitioners or nurse, like RN nurse.
All right. If I see a note to it, in a few minutes, I will let you know. A few more questions. Let's get on to next 2-3 questions. So the next question is, do the items reviewed need to be attached to the note or refer to test and image apply? If I list date of exam lab, referral note, review date, are these notations acceptable? Would you like me to repeat that, Kristen, part by part?
Yes, I think what you're asking is, do you have to attach like a copy of the MRI that you reviewed, and that would be a no. You would just list, MRI of the abdomen reviewed. You don't have to, have a copy of the MRI there. With the progress note, sorry.
Okay. So this is again related to a CPT code. What CPT code can be used for just a nursing visit if 99212 has to include a minor problem?
So 99211 is still going to be active. So you can only do it on established patients. And then 99211 has no time associated to it. And I can include a description of that in the slides as well, if that helps.
Okay. The next question is, if telemedicine is used, are there specific codes for these services?
So right now, during COVID-19, the telemedicine codes are going to remain the same. So you're going to use your normal E&M code as if the patient were in person, or your phone consult codes if you're doing audio only. So for the moment, that is not going to change. Now, there is a lot of talk from the payers, that the pandemic or COVID-19 stuff is going to end in December or the end of October, but they're all stating that they're going to publish updated guidelines around telemedicine. We do have another webinar on that, what the payers are saying about the changes to come to telemedicine specific after COVID-19. And then once we know what those changes are, there will be another webinar just detailing how telemedicine is going to change in the future.
Okay. The next question is, can you give us the URL for the ebook? So maybe, Kristen, you can add that to the slide. Yeah.
I can add that to the slides for you so you know where to go to download them. I do recommend that you do the ebook version though. It'll give you the option to either buy the book where they mail it to you, or the ebook, which is pretty much instant access. So I would do the ebook.
Okay. All right. The next question, when doing an in-office injection with the appointment, would that go towards time if charging for the injection?
No.
No.
So if you're going to get paid separately for the injection, it's not included in time.
Okay. So the next question is, are there any difference from what you're saying for specialists? So anything that is different for specialists?
I guess it would determine what specialty you are. Like if you're a hospitalist and you see a lot of hospital patients, yes, it is different. I can send more information as well on those.
Okay.
So it kind of depends, like physical therapy, psychiatrist, hospitalist, theirs are going to be different, yes.
Okay. So maybe we can add more information on this.
Yes, so I'll add a pamphlet that Dia can send with this that will kind of detail that more for you.
Okay. So the next question is, what type of education self-report issues are you referring to? Are they for attention deficit, something like that?
Yes, yes. So if the patient is saying that they feel that they have this psychosocial issue or ADHD, there is a section saying that they can now self-report. But the doctor would want to make sure to notate that they're self-reporting.
Okay. So if you do x-rays in office, does ordering the test count as ordering a unique test?
No, not if you're doing it in the office.
Okay.
I assume you mean would it count kind of like time when you're ordering? But if you're doing it in the office, you're already billing for it and getting paid for it, and then you cannot.
Well, it would count towards MDM, not time. If it depends on if you're using MDM or time.
Okay. So the next question is, how do you reactivate the old codes?
So let me just exit this really quick so I can show you. Oops, there we go. Okay. So settings configuration. And there is the CPT ICD section right here. So you can open the CPT section. If you click on any one of them, you see this drop down here that says active, inactive, all. You can click all or inactive. Find the code, and there's a little checkbox right here. You would just check it or uncheck it. So that will allow you to, if you do have open encounters that are older, it'll allow you to get those closed with your current ICD codes that are picked.
The next question is, do we need time documentation of time on annual visits? They are billed per age bracket.
No, but I'm going to send a pamphlet in regards to that as well, just to clarify on the, annual visits or well visits.
Okay. So the next question is, can a 25 modifier code still be used?
Yes. I mean, you would use it in certain circumstances, so yes.
Okay. All right. Yeah, somebody is requiring Melissa's contact, so I think we would be sharing it, putting it in the slide so everybody can have access to both Kristen and Melissa's contact details, as well as the URL for the ebook that Kristen was talking about. So moving on, the next question is, if labs are drawn during the visit and they come back in 2 days, when the provider then reviews them, is that time counted towards that previous visit?
No. They're saying that it has to be done on the same day. The non-face-to-face activity has to be done on the same day as the visit.
Okay, all right. So let me take on next few questions, and they are the same. They are again related to my EMR coding question is, are most EMR systems able to upgrade these changes?
I don't know about other EMR systems. Yeah. I know ours is yes. I would think that they are yes. But you would want to contact your EMR and just make sure.
Okay. And there is a request, the very last question, Kristen and Melissa. So there's a request for, could you please repeat the name of the ebook?
Oh, it's the AMA's, they call it like the ICD10, the 2021 ICD10 coding book. It doesn't have a fancy name.
Okay.
I mean, it's pretty much, it's not fancy.
Okay. So that is it. We covered, all the questions. Just one last, which just came in. How does this affect transition codes when billing for a hospital follow-up?
So those are not changing. So I will attach information on that. So the only codes that are changing for the MDM or time is the 99202s to 215s. 215. Other codes are not changing in regards to being allowed to use time.
Okay. All right. So that is it for all the question and answers. And Kristen and Melissa, I have noted the questions that we said we will get back on. So I will provide you with all the emails. So thank you so much to both of you for all your information regarding the changes that are coming up, for all the answers to all the questions asked. And I was wanting to tell everybody again that we will have the PDF and the recording over to you in the next one day. So thank you so much to all our attendees for their interest, for the webinar, for all the questions. You can access it once again. So thank you for taking out the time to be here with us. Stay safe and stay healthy, all of you. Bye from all of us.